So let's just get into the topic. So there are some, basically just some cases. So cases will wake you up, hopefully. I'll ask a lot of questions. And the more questions you answer, the more fun it will be. So this was a 22-year-old male. He presented with fatigue and fever for 2 months. And he was found to have AML. And he was started on the induction chemotherapy. Right, following the first cycle, he went into the febrile neutropenia and developed unrelenting high-grade fever. Right, very, very common thing we see in many of the hospitals after chemotherapy. So, what are the differentials here? So, in a febrile neutropenic patient, you know that they go into sepsis very quickly. There is bacteremia because of mucositis and reduced immunity and many other things. So this was the first differential, bacteremia due to gram-negative or gram-positive, right? Then there can be candidemia because candida is also a normal part of the gut, right? So gut translocation due to mucositis, we all know that, right? Anything else you are thinking of? Anybody? "22-year-old male with acute myeloid leukemia following first cycle of chemotherapy." You would think of gut pathogens, bacteremia, candidemia. Then anything else? Anybody? Hey, Bittu kidhar hai? Bittu, Aditya, I am going to pick on you if nobody is answering. They have disappeared. Yeah, so it can be simple urine infections, it can be line infections. Suppose he has undergone chemotherapy, so there may be a chemo port, there can be port infection, this, that, right? So those are the common things we think of. It can be pneumonia, many things. So, this is what grew in the blood culture. We found an Enterococcus faecium, which was resistant to penicillin but sensitive to Genta and all this. And this was a central line collection. He started on ticoplanin, but he continued to spike. So then, after 3 days of therapy, he grew E. coli again in the blood, and with a very high PCT. Right, and now this E. coli is carbapenem resistant. Right. So this is another thing I want to point out, that in the immunocompromised patient, you can often have multiple pathogens. So in the community acquired patient or the community setting, if we find one bug, we get very happy and we are done. We just treat that bug and we are done. In immunocompromised patient, you may get multiple pathogens, so you can never rest. एक चीज मिल गया तो खुश नहीं होने का. Right now, this was so ultimately he did not improve and he succumbed. So the focus of this is going to be approach to the immunocompromised patient and infections in them. So I will not focus too much on therapy. So this was case 1. Just keep this in mind. Young patient with myeloid leukemia, bacteremia with 2 different bugs, and did not improve. Right, this is another case. This was an elderly lady. She presented with dry cough and dyspnea for like a subacute duration, 3 weeks to about 3 weeks for cough and 2 weeks for dyspnea. So what are your differentials at this point? Elderly lady, dry cough and dyspnea. You can think of
ILD.
Yeah, ILD, yes. What else? ILD, COPD, all these are there. In terms of infection, if you have to think. Yes, TB could be the first and most common thing we think of in this situation in our country. Anything else? So now this was the X-ray. You can see there is some more like an interstitial pattern you can see, right? So now what are you thinking? So in COGS you would expect focal pattern. Now you are seeing an interstitial pattern. Elderly lady with subacute cough and dyspnea. So now I have not mentioned what immunocompromise she has, but suppose she has some sort of immunocompromised state, because this lecture is on that. So can you think of any bugs?
Fungal.
HIV.
PCP, fungal, what else? Anything else? Okay. So basically PCP, fungus, then CMV is a possibility, and some other pathogens are also possible, right? So now this was the chest CT findings, a lot of ground glassing with some peripheral sparing, right? So our impression on the X-ray is kind of confirmed by the CT. There are no focal findings. It's more of a generalized ground glassing, right? So why are we not thinking of something like a staph aureus or a strep pneumonia or anything like that in this patient? Yes, very good, correct. So firstly, it is a subacute thing. Secondly, patient is not having high fever, patient is not septic or anything. And secondly, the pattern is a generalized interstitial pattern or a ground glassing pattern, whereas in the strep pneumonia and your classical extracellular pathogens, you would see a focal pattern, a focal consolidation, or a bronchopneumonia pattern with multiple patches and all that. But this is like a different pattern, right? So this was a subacute interstitial pneumonia. So it was initially, so patient had gone somewhere else. Initially it had been diagnosed as a hypersensitivity pneumonitis or a ILD. But when we examined her, we found some hepatic vesicles on the labia, and she was then found to be HIV positive. So now what Dhanashri said very astutely, first thing she said is PCP. So that seems to be a very high on the cards, because now seropositive patient with ground glass interstitial pneumonia, chronic or subacute chronic and dyspnea, the first thing you will think of is a PCP, correct? So the BAL showed this kind of thing. So this is not the actual image, this is just a representative image. I couldn't get it from the pathology. So these are cysts in this stain that we are seeing, right? So this person had a PCP, she was treated with the TMP SMX and she improved. Now just go back to the first case. Patient had bacteremias, culture positive, was very sick and succumbed very quickly. Whereas this patient had a chronic subacute history, not very septic, not very high fever, and she improved with the treatment, correct? So these are two broad ways of things, and this is where the most important thing is all immune compromised states are not the same, right? So the first patient had a myeloid leukemia and had a febrile neutropenia, which is a very dangerous condition, whereas the second patient did not even have fever. She was seropositive with low CD4, that is why she got the PCP, and she had a lung infection, but she did not have fever. So I just want to highlight that what organisms and what immune deficit happens in the neutropenic is very different from what immune deficit happens in the HIV positive patient with a low CD4, and the bugs that you expect and the presentation that you expect are also very different. So you can't have a broad label immune compromise means sub inspection हो सकता है, ऐसा नहीं है. There are very clear ways and there are very prominent things which are more common in one type and less common in the other type, right? So acute infection, sepsis, hypertension, shock, bacteremia, high procalcitonin, these are the things we see in the neutropenic patient, and these are generally what we see are extracellular pathogens which come in. Whereas in the HIV positive with low CD4, you would see subacute infections more commonly with the preserved blood pressure, normal procalcitonin, gradually getting worse, and more of intracellular pathogens because there is a T cell deficit kind of, and here there is a neutrophil deficit and some B cell deficit. So here you see these kind of things, and here you see these kind of things. So all of these organisms have their sources and their different presentations, but just to highlight that different immune compromised state and you get different kind of bugs you expect. Of course, this is not a hard and fast iron tight rule. I mean, an HIV positive patient can obviously get an MSSA, MRSA, pneumococcus, everything, but the pattern has to fit, the syndrome has to fit, and what you expect in what situation is a little bit different. So approach has to be a little bit different. So in HIV positive patients we get viruses, fungus, parasites, intracellular bacteria, whereas in the neutropenic patient you get these extracellular bacteria and the candida, right? And also if you think, this kind of demarcation helps in the post-solid organ transplant patient as well, where somebody is post-renal transplant or post-liver transplant. In the first few days to first 1-2 weeks of the transplant, you are not going to think of the ones on the right side as intracellular bacteria. You are going to think of the left-sided bacteria, which are extracellular pathogens. So nosocomial infections, sepsis, these are the ones which you see in the early post-transplant period, whereas the ones on the right side, PCP and all that, that's what you see more in the later on post-transplant. So all those numbers are there. I don't by heart them. You can find the charts anywhere. So each of these bugs also has a specific organ they affect and they present accordingly. So now this is something I just kind of for my own benefit, I made this kind of pattern recognition during my infectious disease fellowship in Hinduja. So I used to make these kind of triangles. So on the top of the one corner of the triangle, you can see the syndrome, and then you can see the host factor, right? So then you have to guess the organism, right? So this already we discussed, so we know, right? So the third corner of the triangle has to have the bug, right? So we are thinking of PCP, CMV, LIP, some other things can also be there, but commonly these are what we think of. If CD4 is above 50 but less than 200, we are thinking PCP. If it is less than 50, it can be CMV also, right? Then we come to this kind of thing in the neutropenic patient with the acute lung nodule or acute focal pattern. What will you think of? This also we already discussed. So we think of aspergillosis, MSSA, MRSA, Pseudomonas, right? Now we are thinking, so if there is a chronic pattern, a chronic focal infiltrate or a nodule in a post-solid organ transplant or the HIV patient, then what are you thinking? Anybody? Chronic means suppose somebody has fever, cough more than 2 weeks, 3 weeks, 4 weeks duration, HIV positive patient, focal finding on the lung. Anybody? Coughs, of course, then what else? Fungal aspergillosis again possible, then what else? So whenever you say TB, you have to say NTM also in the HIV positive patient, right? Then anything else? Bittu, Aditya? You very cleverly missed most of my lecture because you knew I was going to ask questions. Nocardia, nocardia. Right? So in this situation we can think of nocardia, TB, NTM, ileoid, that kind of thing. Right? So based on the host and the syndrome, one can often predict the causative organism, and then sometimes we do the opposite also. So this same triangle we can use in different way also. So you get a bug and you know the syndrome and you go back and try to say, okay, this might be the immune compromise here. But here, of course, you have to be careful because what you may have isolated may be a colonizer or a contaminant. So you have to use this kind of thing with a caution. But suppose, pediatricians will know this very well. So patient, child comes with recurrent skin infection, then you think of something called a CGD, right? So from the bug you isolate from those skin abscesses, you can go back and think, okay, is this CGD, right? So this is what we discussed. So neutrophil, humoral and cell mediated, both are specialized for different type of killing and activity, right? And so now suppose there is a meningitis in a neutropenic patient, you are thinking of pneumococcus or MSSA. In the HIV patient, you are thinking of TB and cryptococcus. So with that I come to the end of my presentation. Thank you.